a nurse is assessing a client for fall risk. This is one of my favorite. Falls are always favorite of NCLEX too. Which of the below should be included as a risk factor? Okay, so basically it is asking who do you think or what problem or which client would you think that is going to be at risk for fall? Okay, it's in risk reduction area. So a client who is 56 years old and male, client who has nocturia, a client with a history of fall, a client who is NPO, and client uses an assistive device. Which one would you say is at risk for fall? All right. Good job. So, you ready for another concept map? Okay, this is for the fall. So, let's do this. Right. For the fall, we did a fall risk kind of concept map before, but I just wanted to talk about it one more time. So these not just the risk factors, okay? Anything which is regarding fall, I would like you to think about this, all these areas. There could be outside factors, okay, and there could be risk factors. We'll talk about risk factors later, but there could be outside factors which might be adding to the fall, and that could be environmental hazards, like a throw rug is there, or maybe the patient is just using only socks or something and is sliding, or maybe the area is wet and it's like or like there was some water somewhere spilled or some fluid filled and spilled, and then they might be sliding on that. So those kind of environmental factors, or maybe there is like cords like this and they trip over there, so kind of think about all those kind of environmental hazards when you get a fall question, because we need to fix that, especially if there is a question where it says you are a home health nurse, or something about you are assessing the client in their house, and you are trying to see if there is a fall risk or if there is something there which needs to be fixed, or maybe you are trying to evaluate for a need for education. So in those kind of cases or all those kind of questions, look for those environmental hazards which might be there. Okay, so uneven kind of flooring, like there is like lots of steps or something, or you may not really realize there is a step and then you might trip over, right? So those kind of environmental hazards are one. Then improper use of assistive device. Even though when we think about assistive device as a good thing, I'm like, oh, you're using a walker, great, you are more stable. I mean, that's the first thing which comes to my mind when somebody says I am using a walker or I am using an assistive device. But the same thing could be a hazard or kind of a risk for fall, because they may not know how to properly use it. Like I still remember there was one of the patient, and I just wanted to going to use this board as that. So she has a walker. Okay, so just think about this as a walker, okay, and she's holding the walker like this and walking, and I was like, wow, that's not going to be helpful. Sometimes they do that. They're like, I'll just hold on, and whenever I need it, I will put it down. I mean, that's not how you do. That's going to add to the hazard. So those kind of things we have to be very careful. Improper use of assistive devices. Then of course about the disease conditions which could be adding on to the problem with the patient risk for fall. So that could be neuro problems, like they have seizures, or they may have a syncopal episode, or electrical abnormality in the brain. It could be delirium or confusion and things like that. It could be something with the cerebellum, or maybe a stroke. Those kind of problems can cause coordination issues, right? So that might be problem. Cardio, like maybe they have hypotension and they get or orthostatic hypotension specifically, they might get so dizzy and they might fall. Or maybe they have heart block, complete heart block, or they have they get so bradycardic that they dizzy and they might just go down. So those kind of things. And bleeding, again, I'm just putting it in the cardio because it's cardiovascular. So when somebody is having shock or bleeding, hemorrhagic shock or hypovolemia, those things can also could be an issue. Ear problem, we know about the ear vertigo, and they get this balance issue from that, and they might fall. And infections can cause somebody to fall, especially when they have sinusitis and or UTI. Patients may get so confused sometimes with UTI and they might fall. So a lot of issues, right, which could be contributing, disease conditions which could be contributing to fall. So but as NCLEX looks for them, if you get any of these conditions specifically in the question and they are saying that they are orthostatic hypotension or they are having vertigo, make sure to start or initiate that fall precautions for them. I mean, they may not be falling right now, but there is a chance. So we need to be careful. That's what risk reduction is. And risk reduction is a part or a client need in your NCLEX exam. You have to get above passing standard in risk reduction. So these kind of questions, very important for you to pass, right? Okay. So the other one, this side, we are going to talk about the fall risk, the issues here. Most of the time it's a movement or a gait problem. Gait meaning like walking, I mean they don't know how to walk, or maybe they have a movement disorder, maybe they have musculoskeletal issues or neuromuscular coordination issues, maybe they have Parkinson's disease, maybe they have GB syndrome, or maybe they have ALS, or maybe they have myasthenia gravis. I mean it could be anything which is kind of connecting with the neuro and muscular part, and it could lead to any kind of fall. And it even can be like arthritis kind of issue where your skeletal issues or bone issue or joint issue, and then could be an issue there too, contributing to the fall. Okay, level of consciousness changes. LOC is level of consciousness. It's just my way of writing small things. That level of consciousness, right? This confusion and all those problems which could be there. History of fall. Okay, if you already have a history of fall, man, I'm going to put you in fall precautions because I don't know what's going on, right? So that itself will give me a risk. Incontinence or maybe nocturia, where they have to get up at night and go to the bathroom. So that could be an issue, especially if they have visual problem like sensory, I mean they cannot see properly, and if they have to get up and go to the bathroom, and that could be another hazard waiting. Medications, where they might be like dizzy or side effects of the medications which make them sedated or make them confused or make them like weak, those things can add on to the risk of fall. Well, now you know all the risk of fall and what to do and everything in one point here. Like you have this map is going to help you. So that's really good information for you. So what do you think here? Client is 56-year-old and male. Oh, thank you, Victor. Okay, so what do you think about this? I mean, I'm not going to take that, right? I mean, just because somebody is 56 years and somebody is male doesn't increase their chance of fall, right? So thank you. So that's not going to be our answer here. So we are not going to take that. Client has nocturia, yes, because nocturia is, at night time they have to go. So that could be an issue. So I would say yes. History of fall, yes. If you have history of fall, I'm going to put you for fall risk. Okay, NPO. Now, just because somebody is NPO doesn't mean that they are going to have problem, right? Maybe they are NPO for a procedure. Maybe they are NPO, but they are getting IV fluids. So there is nothing which tells us that this patient is having hypovolemia or hypotension or sedation or anything like that. So we don't want to read into the question, right? We just want to stick with what is written here. We don't want to overthink. If it says here the client is dehydrated, okay, I will take it as a problem, secondary problem. Or if it says the client is hypovolemic, or client is bleeding, or the client is having hypotension, something like that, okay, then I will add it. but this itself is not going to be my answer. Okay. Client uses assistive device, like we said, even though we love it, but we don't know how they use it. So I'm just going to put it as a risk. I will have to ask the client to demonstrate to me how to use the assistive device or how they are using it. And if it is proper, then that's good. If not, we will have to include it. Okay. Sony is asking, is there any chance NPO can make a person pass out, like dizzy, if they are not adequately hydrated? So whenever somebody is, when somebody is NPO, then we also have to make sure that they are not dehydrated, right? Give IV fluids or whatever is needed to keep them, properly, adequately hydrated so that they won't have any problem. Okay. All right. Okay, now we know that. There is one more thing I wanted to mention. I remember we discussed this with another question in one of our webinars, but I hope you remember Moore's fall scale. This is the one which most of the hospitals use to assess the client when they come, like, the initial admission assessment or the things which we do, or every day when we assess the patient, we might be doing this, or whenever the patient's situation changes, like they had a surgery or they went from a critical care area to another area, or anything that changes the status of the patient, we will be doing a Moore's fall scale for them, just to make sure that we know what to do. So if they have a history of falling, or secondary diagnosis, which we discussed, or if they are using something like assistive device, or if they have an IV, or if they have a movement problem or a gait problem, or if they are confused, level of consciousness changes. So each of these things will get points, and we add all of them. And if they are up to 24, then no risk. We just do standard care, and we monitor, and anything changes, we will take care of them. But if it is 25 to 50, they come under low risk. So we will do standard fall precaution interventions, and that depends on each hospital. What do they do? I mean, some of the things I can mention is, we are checking on them every hour, or we are making sure that there is no clutter in the room. We are making sure that there is call bell is within reach, or maybe they have the bed alarm on, or if they are sitting in the chair, there is a chair alarm which is available, or maybe there is somebody else in the room watching them, or making sure that they have all their personal stuff nearby, the bedside table and everything is there. So yeah, every shift you might have to probably do this. So depending on each condition, if they are very high risk, we might change the room to near the nurse station, or maybe we will, if it is really, really bad, we might have to institute, really like restraint kind of things, but that's always the last resort. We don't do that. Maybe 101 sitter or somebody who is always watching them. So Dali is asking, do we have to by heart this like GCS? No, you don't have to. But I just want you to know, not the number. You don't have to remember the number, but I want you to know these 6 things which are included in them. Like, what are the things we might look for when somebody is assessed for fall. So just remember this way, and also remember this part. Like, if it is up to 24, it's okay, like normal, and that's okay, that's enough. You don't have to separately remember yes or no and how much is the point. No. But Glasgow-Coma scale, yes, you have to. Apgar score, yes, you have to. Rule of 9, yes, you have to. Okay, those things we have to remember. All right, so I know I did a little bit over today, but I'm hoping that it was very helpful, especially with our concept map, and I keep working on it. I'm going to come back with more, right? So please remember, very good, connect the dots. Remember to connect the dots, because that's exactly what is going to help you to become successful. And we have to learn in the new ways. We have to learn in the innovative ways. There was a time earlier, maybe when I was writing NCLEX exam, there was a time when theory was enough. There was a time when remembering points or content was enough. Not now. Not anymore. Anytime in the future too. So nurses are supposed to be clinically judged and clinically really good in critical thinking and decision making. That's what a nurse is supposed to do, which means we need to have the content, but that's just the halfway. The other half, we get it by connecting them. What is going on with this patient this time? And please remember, every time it is not just the theory based, it's the context based. For this patient, what is right may not be right for this patient, but you know what I mean. So